First of all, I have no conflict of interest. And secondly, I'll start from this general slide in which the debate for all the endometriosis and uterine disorders is, do I do surgery or medical treatment for my patients? This is common for endometriosis, adenomyosis, and uterine fibroids. I will talk with you those three disorders. And in all cases, I will mention that the decision will depend on the age of the patient, on the symptoms, and on the search of fertility. Let's start from the leiomyoma. Leiomyoma is one of the causes of abnormal uterine bleeding. You know, it's a very common disorder. And the question we have all the time is, what is the medical or surgical treatment again? And you see here the age, the wish to preserve the uterus, the wish to preserve fertility. This is a meeting correlated to IVF. We have to save the uterus. So we have to decide between to remove the myoma or to do a medical treatment. And you know, the medical treatment are very invasive, maybe hysterectomy, but for fertility preservation, you have to do myomectomy. But you have also medical treatments, the GnRH analogs, progestins, oral contraceptive, levonorgestrel IUD, SPRM, and new treatments also, uterine artery embolization, MRI-guided laser ablation, and HIFU. So now the choice for doctors, for gynecologists is much better. You know, these are the newest one, uterine artery embolization. These are the new treatments, and represent a valid and non-invasive alternative to surgery. You see here the MRI laser, the HIFU, and poorly recommended in women who want to preserve their fertility, because unfortunately some of those technologies do not allow a good pregnancy and the risk of a possible complication of pregnancy. So one other option is to stop this bleeding and to reduce the volume of the fibroids is to use drugs. I mentioned to you, this is a nice guideline 2018. Ulipristal is one of the drugs. This is one of the publications by Jacques Donnet, in which he published the Pearl for trial. Until 1 year ago, this was really a good treatment. We had 900,000 women were treated with this drug, also for multiple 12 weeks, then stop, other 12 weeks, even 4 different courses of treatment. You see here 1 course and 4 courses. You have a very big reduction volume, even 80% or 78% of reduction of the volume. So this was a very good treatment. The publication with successful pregnancy from Felice in Spain or from Jacques Donnet in Belgium, pregnancy, women treated with ulipristal acetate have a conception and favorable pregnancy outcomes. However, in 2020, EMA stopped the treatment for ulipristal acetate. So probably we will have some more drugs in the future, but because of liver disorders, there were 6 patients who had to receive a liver transplantation for this drug. Now the procedure to use the drug are much more complicated and less diffuse. So the policy to have a selective progesterone receptor modulators will start with the new possible drugs in the future. Jacques Donnet proposed this cartoon, this flowchart, in which you have also hysteroscopy for some myomas, hormonal treatment when you have a small myoma, type 2, 3, 4, 5. And if you have an optimal response, you may try to conceive. If you have a satisfying response, you may try to conceive, or you have if there is an endometrial cavity, you have a surgery with myomectomy. So if you want to have a baby, the medical treatment are really useful because you reduce bleeding and volume, and then you can try to conceive. Otherwise, you go to the myomectomy. This is depending on the age you have and on the type of fibroids you have. And if you have a type 7 and type 6 or 7, you don't need any treatment. You can have your pregnancy without any problem. For adenomyosis, it's more complicated or more simple, depends, because this is adenomyosis are endometrial glands located in the myometrium. You see here, this is the normal uterus, this is a diffuse adenomyosis, this is a focal adenomyosis, this is a nodular one. Depending on which one you have, you may have heavy bleeding, infertility, and dysmenorrhea. And these are the mechanisms implicated in altered uterine receptivity, infertility, abortion. So you may treat your patient very well with IVF formulation technologies, but the abortion is really very often in these patients. And there are no specific indications for adenomyosis management, surgical or medical. Canada, World, ESHRE, American Royal College, you see even Society of Uterine and Endometriosis Uterine Disorder, we are trying to develop a real good management. What we have again is IFU, uterine artery embolization, hysterectomy, fertility sparing procedure, or for women who have no fertility, you can have also surgical removal of the uterus. It's very common. If you want to have a medical therapy, this is a paper we published in Fertility 32 years ago, you may have the same drugs we used for the fibroids. You have GnRH analogs, you have progestins, which are much common for endometriosis, levonorgestrel IUD, oral contraceptive, and non-steroidal anti-inflammatory drugs. These are drugs which may use, but they are off-label. You see here one of the drug which is becoming more popular because of the double-blind randomized studies is Dianogest, is a progestin. This is Yutaka Osuga from Tokyo. He has several publications now. It's very good, it's very useful. Pain score works very well. Dianogest 2 milligrams per day is very effective and well tolerated. And you see here, this study recently published that you may have potential benefit on embryo implantation. So if you have a suspect of adenomyosis because of your MRI or ultrasound, you may treat your patient with Dianogest and the implantation will improve. You see here, this is the mechanism of agonist of analogs, anti-proliferative effect on myometrium, apoptosis in adenomyosis is increased, local hypoestrogenic effect, you may improve fertility. This is a paper, the same paper on fertility and sterility. And this is a combination, you may have a Chinese study, combination of GnRH analogs and IFU for decreasing volume and adenomyotic lesions. This is a very recent review. This is a systematic review meta-analysis. Levonorgestrel IUD works very well for adenomyosis, reduction of pain, reduction of IUB, reduction of uterine volume. So you may obtain your aim to reduce pain, to reduce bleeding, but also to improve fertility. These are 10 studies. You see here, this is a very recent publication, 2019, on the Acta Obstetrica Gynecologica Scandinavia. So you may, if you have infertility or desire of pregnancy, you may start with the medical treatment, or with ART, or with medical treatment. Then if it's not successful, you move to the surgery. What about endometriosis? The last 10 minutes I will devote my presentation to endometriosis. In 2021, we have, again, this is a disorder of infertility and pain. The same story. We have a much more improved the diagnostic, symptomatology, imaging. We are working very well now on the diagnosis, much improved. But we have also to realize, because we treat infertile patients, the comorbidity. And this is a big issue for treatment of endometriosis. Then you can go to ART, to laparoscopic surgery, to medical treatment. Again, the same story for these uterine disorders. The choice is between laparoscopy and medical, or if you want to have a baby, you can start immediately with your ART. What is important in this moment, in the last 10 years, from the Canadian, they started in 2010, empirical medical treatment may be done without laparoscopic confirmation. So this is very important. We don't need to do laparoscopic diagnostic evaluation. We can give, according also to Wes, Eshre, Wes, and also Seud, we are proposing empirical medical treatment. And you see here, we have several drugs from 1975, danazol, MPA in 78, GnRH analogs 25 years ago. Now we have Dianoges, 2010, and many oral GnRH antagonists are coming on the market. So much better. The last decade and the next decade, we will have even more. And you see here, this is a very nice publication by Bob Casper on fertility and sterility a couple of years ago, in which he says that biological data and limited clinical evidence support a potential adverse effect of oral contraceptive on the progression. So he proposed on this publication that progestin-only pill or progestin are much better for the treatment. And Dianogest is really, in the last 10 years, is really 2 milligrams per day, is working very well. Treatment may have some vaginal bleeding at the beginning, but it works absolutely very well. Works on the endometrioma. You see here, before and after surgery, because you have no recurrence of endometrioma. If you have a recurrent, you may have, after 20 months, you have a resolution of the, with Dianogest of your recurrent endometrioma. So works very well on the cyst, work very well on the deep infiltrating endometriosis. You reduce dyspareunia, dysmenorrhea, and pelvic pain. Is very effective. And you can treat also for 5 years. This is a very common question. If I am very young, a patient, do I may be treated for a long period of treatment before to do any pregnancy or surgery? Yes, you can do. It's very good drug. If you want a baby, you have to do cystectomy prior ART. No, Eshre guideline says that not perform cystectomy because you reduce ovarian function after surgery. So it's much better to treat with some drugs before ART and then you do URT treatment or before deep infiltrating endometriosis. Again, the effectiveness of excision to the deep before ART is not well established. So it's growing and growing the evidence that you don't need to do surgery before IVF or ICSI, whatever. You need to do a good medical treatment. You reduce pain, you reduce many symptoms, and then you can start with your technologies. One possible is to give analogs. This is well established by Eshre. Medical therapies as an adjunct treatment. You can prescribe the agonist period of 3-6 months prior assisted reproductive technology. This is a paper which was published Garcia Velasco in Spain, but the other publication confirmed, and also Eshre suggests that you can use. Now is becoming popular GnRH antagonist. In fact, you can use without stimulation of, you can have no flare up, so it's good. Suppression of LH, FSH, and different level of hypoestrogen, sometimes without flashes. And in the market now we have, in the United States, only United States, you have elagolix, neuro-oral non-peptide GnRH antagonist. This is very comfortable. There is no injection, it's oral. And you can give once a day, 150 milligram or 200 milligram twice a day. And there are some publications on New England Medical Journal by Hugh Taylor and a big group of colleagues who published that is very good on pain. And new studies are coming. This is a fertility sterility 2020. Again, Yutaka Osuga from Tokyo published this relugolix, an oral GnRH oral antagonist, which reduces endometriosis pain. This is a randomized double study, placebo-controlled study. So it was a phase 2 study. And you see here you have a reduction with the relugolix, which is different from elagolix. Remember, there are 3 now coming. The third one is linzagolix and was published again by Jacques Donnet on 2020 in fertility sterility. Again, phase 2 study, double-blind placebo-controlled, Edelweiss study, but the name is linzagolix. So Elagolix is already on the market. Relugolix is starting to come in 2021. Linzagolix probably 2022, but we have at least 3 different antagonists and we can use for the treatment of endometriosis in our patients before ART or before surgery or before whatever is a very good option for us gynecologists. And you see, this is my last slide in order to summarize to you the indication for medical treatment in endometriosis. Remember, in the young women in reproductive age with pain and not desire of pregnancy, give a drug. Empirical treatment may be used, is very, absolutely very comfortable. You can have a good treatment, a good option, and the drug works very well on pain for long term. Then if you, the second option is you can give when surgery is contraindicated or refused for previous medical surgery. Because sometimes patients come with a recurrence, they don't want surgery, give a medical treatment. The third option is prevent recurrence after surgery. There are publications now showing that you may have 2 or 3 surgeries, recurrence, 5 recurrences after surgery in endometriosis because the disease is still there. In order to prevent recurrence, please use a medical treatment. So much more than in the past. Much more possibilities, progestins and GnRH antagonists, and many drugs will come even more in the future. So endometriosis is absolutely a field, and uterine disorders and adenomyosis are 3 fields in which we will have many more drugs. This is the situation now. Hormonal drug, FDA approved leuprolide, nafarolin, goserelin, elagolix, but not the diagnostic, unfortunately. While in Europe, the EMA is proving the analogs and the progestin. So in Europe, we have these new drugs. In the United States, they have elagolix, but probably now in Europe, we will have also relugolix and other drugs. So it's a big issue, very important field of investigation and application, satisfaction. Patients are really satisfied. We have 10 years experience on these drugs and really is working very well also on fertility and fertility success rate. Finally, I remember you that endometriosis is a chronic disease. You see here medical treatment in adolescent, fertility age, you may have ART before surgery, medical treatment when you have already your baby to prevent recurrences. My last slide is just to thank all the team of radiologists, anesthesiologists, and young gynecologists who are collaborating with me for the success of this field. And we are really generating a big center for endometriosis and uterine disorders in Florence. And it's really an open area where we welcome to everyone.